From theheart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Weill Cornell Medicine, and I'm here at the ESC in Madrid, Spain, really having an opportunity to see the latest clinical trials in cardiovascular medicine, but maybe more importantly, having the chance to catch up with friends and colleagues from around the globe to talk about the latest issues in cardiovascular medicine, science, research. Really what I want to talk about today is something that I know has been of keen interest to people in Medscape cardiology audience, and that is cardiac prevention. This is really a big change. Over the years, the focus has largely been on how do we treat the consequences of cardiovascular disease. But I would say in the last several years, there's been a major shift towards trying to understand who are people at risk and how do we prevent them from having cardiac events. So I'm really fortunate to be joined today by two good friends and colleagues to be able to have this conversation, and certainly they bring a lot more expertise to the stage than I do. So first, Dr. Fatima Rodriguez. Fatima is an associate professor of medicine in the Division of Cardiovascular Medicine at Stanford University, where she's also the section chief of preventive cardiology. So thanks for joining us.
Thanks, Bob.
Next to Fatima is Paul Ridker from Boston. Dr. Paul Ridker is the Eugene Brunwald Professor of Medicine at Harvard Medical School. He's also the leader of preventive medicine and cardiovascular medicine. So Paul, thanks for joining. Paul and I also have a lot of experience in working on trials together as his regular DSMB chair. So thanks,
Bob. You help us out in many different ways.
So let's start, Fatima, with you. And as we think about prevention, what I'd like to do is let's do assessing risk. How do we decide who might be eligible for treatments? Let's talk about some of the new data. Then let's move to a discussion about things like advanced imaging, whether that's CAC or whether that's CT angio. I mean, particularly now as we combine anatomic information with physiologic information non-invasively, how do we think about that? Let's talk about biomarkers. I know, Paul, certainly one of your areas of expertise. And then let's talk about treatment. Sound like a good?
Sounds like a great plan.
All right, we're going to do all that in 20 minutes. So let's start with you, Fatima, and let's talk about traditional risk assessment. You're a preventive cardiologist. How do we do this?
Well, first of all, I'll start by saying that it's a great time to be a preventive cardiologist. We see that our trainees are excited about it. There are new therapies that we'll talk about. And I'll make a note that I was Bob Harrington's fellow in clinic, and he calls himself a reformed interventional cardiologist because, again, my focus has been largely on prevention. So the way we do traditional risk assessment is to focus on modifiable cardiovascular risk factors that we think about, like, for example, hypertension, high cholesterol, blood glucose, obesity, inactivity, smoking.
This is the essential 8 that the HA talks about.
Or something's called SMuRF, so standard modifiable risk factors we'll hear more about. And these are really factors that at a population can cause a lot of the attributable risk, particularly for atherosclerotic heart disease. We have several risk calculators that are constantly being updated. Framingham was one of them. Again, some limitations that these are population-based equations. The American Heart Association has released a lot of equations. ESC has different equations. We now have a new equation of the PREVENT equation from the American Heart Association. Again, all of these risk equations consider traditional risk factors. Now, with the new PREVENT equations, we have addition of creatinine and renal function, obesity, but they really work very well at a population level.
So meaning that at the individual level, information may be lacking.
It may be lacking, and something that we see in clinic a lot, especially in my clinic as a preventive cardiologist, is that many of our patients may lack traditional risk factors, but still carry cardiovascular risk.
And so when you're seeing a patient for the first time in clinic, do you routinely, what I'll call, get a gestalt? Oh, this person is a bit overweight, they've got some hypertension, some lipid abnormalities, or do you go through the process of using the scores that are built into the electronic medical record to actually calculate and facilitate a conversation?
I think they're both very helpful. How we communicate risk and prevention has to be very individualized, however. For some patients, I just told the patient, your risk is estimated at 25% based on this calculator, and the patient thought that was great. That means that they're otherwise 75%, they're okay. So I think conveying risk with risk calculators.
Don't go to Vegas with that person.
Yeah, exactly. Yeah, it's actually very challenging. Whereas we'll talk a little bit about this later. Conveying risk, visualizing plaques, something like a coronary calcium scan, is very, very helpful.
Paul, it's got to be the best headline that I'll see this week. SMuRF-less. And so congratulations first off, nice paper, come out in Lancet today. And tell us about what is SMuRF-less and what did you present today at the ESC?
Sure. So like Fatima says, we have risk scores that really generally are trying to predict on a population level, are you higher or lower risk? And they're okay. They're not bad, but they're not great. And for individual patients, they can be quite misleading, is what we're all learning about.
Meaning that they overestimate or underestimate risk or both?
They do both, and that's part of the problem. And you won't know for an individual patient. And also, I think that they're really kind of stuck in a 1970s biology. They haven't really incorporated new things that really matter. Lp(a) is not incorporated, inflammation's not incorporated, and these things really matter a lot for patient care. So a SMuRF is a little blue cute character, which is easy to remember, but a SMuRF is a standard modifiable risk factor, as Fatima said. SMuRF-less are people who have none of those. And you'd be surprised, SMuRF-less people who have a myocardial infarction, Gemma Figtree has been at the forefront of this really, has shown that these patients are frequent, very often women, and their mortality is almost twice as high as people with traditional risk factors. Now, some of that is probably because we don't recognize them, we don't treat them very seriously, and also because it's different biology. In primary prevention, what we've discovered recently is that these traditional risk factors pick up about somewhere between 50 and 60% of most patients. But that's a big gap that's missing. SMuRF-less but inflamed is the new thing that we've presented today. So we went back to our women's health study. We had 12,530 initially healthy American women who literally 30 years ago we started tracking. And we just simply measured their hs-CRPs, and we said, are they low, middle, or high?
You measured that at baseline
we measured
entry?
It 30 years ago.
Okay.
Yeah. On a random blood draw, by the way. It wasn't even a fasting blood draw. It turns out that if your hs-CRP is above 3 milligrams per liter, which is the threshold for kind of higher, these women are at 77% higher risk on a lifetime basis of having coronary heart disease, about a 35% increased risk of stroke, and a 52% compared to the low CRPs.
So the SMuRF-less people with a low CRP versus the SMuRF-less with the high CRP.
That's right. So this is what SMuRF-less but inflamed is talking about. Now, what we presented today, though, was a second piece, because I think we've learned over the years it's one thing to say someone's at risk, another thing to say what will we do about it. We all are preventive cardiologists, and so we'll say, well, look, I'd rather tell a woman when she's 35 or 40 that she should stop smoking and exercise and eat well and do the right things. But we also might want to think about a statin in these people who don't even have hyperlipidemia. So both of you will remember we did this clinical trial called Jupiter a long time ago. Bob, we were involved again. And we showed that if your LDL was actually low, but your CRP was high, you benefited enormously from being on a statin. Well, we went back and looked at the SMuRF-less but inflamed people in that trial. We had 8,800 of them.
So now you retrospectively applied the label to the people who were entered back then. Okay.
So we had people who, well, by definition, your LDL was already low. But now we took out anyone who had hypertension, we took out the smokers, we took out the obese. We had 8,000 people left, and they got the exact same result. About a 40% reduction in heart attacks and strokes and a 65% reduction in MI. Now, I'm not suggesting that SMuRF-less but inflamed people should automatically get a statin. What they should get, though, is a conversation with their physician, which they're really not having. And I think that's the challenge for the preventive cardiology community, is to say, look, yes, our general guidelines work, but so many of our patients are having events that fall outside that, completely outside it, and these SMuRF-less but inflamed people will be completely missed. I mean, their prevent scores are almost zero, but they're having events. And I think we have to recognize that, and we have to start incorporating this.
And I want to make a comment about the risk score. So the risk scores are very, very heavily driven by age and gender as well, right? So if you're a young woman, your risk score by definition will be low. So a lot of those conversations about starting therapies may be just delayed, unfortunately. Again, in preventive cardiology clinics, we have other tools to assess risk. Like you said, you asked this question, Bob, when you see a patient, is it just based on a risk calculator? And the reality is by the time they come see me, there's usually something else going on, a family history. They have incidental atherosclerosis, right? So something else going on.
Well, before we get to how do you take the next step in assessment, let me ask you both, why is SMuRF-less more likely to be women? Do we know?
Well, I think these are the people who may be missed, right? We know there's a long time history of women being delayed in diagnosis when they present into the hospital for myocardial infarctions. Most of them have never, their first symptom, again, of heart disease is an MI.
Yeah. Look, I think we can face the reality that women still, despite everything that WHI tried to do at the NIH, 30 years ago, women are still underdiagnosed and undertreated. Now, it turns out that SMuRF-less men also exist. There's actually quite a few of them. They also get the same issues.
So same increased risk, same benefit from statin.
Exactly.
Okay.
But I think what's really going on here is that men tend to have more traditional risk factors because they just have them. But we're missing a lot of men as well. Yeah.
So let's make sure that we're looking at our entire patient population. So you've both brought it up, other methods of assessment. One of the things that excites me, as you say, as a former interventional cardiologist, is the improvements in imaging through CT. Now, we've had CAC for a long time. More recently, we've had CT angio with now the ability to combine physiologic measurement non-invasively with the anatomic measurement. So let's talk about like patient care. Who are you sending for CAC? Who are you sending for CT angio? And then I'll ask you the same question.
Yeah, I think, again, as a preventive cardiologist, my practice has changed in the past few years with technology and the focus on imaging. And I'll say that particularly before we get to what it does, it really helps have that conversation with the patient in a much better way than a risk score can do. So for most of my patients, particularly those patients over age 40, when they're intermediate risk, their risk scores seem low, but there's something about them that seems high risk, particularly those that are maybe reluctant to take therapies, a coronary calcium scan is usually the start. And this is a gated CT scan without contrast that will tell you very accurately the amount of calcified plaque in Agatston's units. That number really has a graded relationship with cardiovascular risk. Again, this is calcified plaque.
Where's risk start?
Risk starts really at a calcium score above 0, and again, depends on your age. I often will see a young patient with a calcium score of 10 is not normal, right? It should be 0. So there is a threshold, but we know that calcium scores above 300, really equivalent risk for coronary artery disease, and I really tell the patients you have coronary disease. Calcium score above 1,000 Agatston units, same thing, very, very high risk.
So you're getting CAC on virtually everybody?
I would say individuals, again, who are unwilling to get treated, motivate them, or just low risk by traditional risk factors. The primary care community now is ordering a lot more of these tests, and they are referring them to my clinic.
Based on the CAC score.
Based on the CAC score. So they'll send them to me. And before, they used to actually be referred directly to our interventional cardiology colleagues, doctor, for cath. They said your calcium score is high. And now we know, again, the disease, the physiology, that that's not what needs to be done. Don't do that, right, as an interventional cardiologist. But can we use now their biological numbers, their LDL, to treat so that we know how to treat?
Now talk about who do you send for CT angio?
So for CT angio in primary prevention, there is no indication right now. It is currently not covered by insurance. Now, do I get CT scans on most patients with indeterminate chest pain? Very useful, we know, for the symptomatic patient. I do have some patients where I practice, so we'll pay out of pocket for these primary prevention CT scans. Extremely valuable because in addition to telling you how much calcified plaque you have, they also tell you how much non-calcified plaque you have. And now there's AI quantification methods that can help you track the progression of hopefully.
You and I have talked about this in other settings. Yeah.
Very, very helpful again for a specific type of patient. I will say that I'm part of a study called the Transform study that's sponsored by Clearly. We're testing the hypothesis that using this type of...
I'm the DSMB chair.
Yeah.
So
we do, which again is an important question to answer. Does this actually change outcomes in our patients beyond coronary calcium scores?
Paul, that's what's being done in Palo Alto. What's being done in Boston?
Yeah, so I think in Boston, we're probably a little more conservative, but we are shifting in the same direction. It's really a question of what are our primary care docs doing. I think most of them are probably saying, I understand the data. There's no doubt about it that a picture of the disease is going to be better than a risk factor. You have it. You have it, you don't have it. A lot of our folks are probably going to scan the chart for CT scans and other evidence of calcification and say, aha, it's there. I don't need to know the Agatston score. I just want to know it's there. And we're slowly shifting towards more people getting CAC scans. It's inexpensive. The radiation is very low. I think where I'm coming into this, though, is a slightly different twist on this, which is that I like the imaging as a way of saying who has the disease in primary prevention. But remember, the image tells me nothing about what the biologic driver of that individual person's disease is. So we've been trying to get a marriage between the modifiable biomarkers and the imaging. So what we've been talking about is get the imaging test to say, aha, this person's primary prevention, but they have the disease, I need to intervene. And then I still need the LDL. I think I need an Lp(a). I think I need a CRP to say, is my intervention going to be anti-inflammatories, they're going to be simple lipid lowering. If the trials work out, might it be LPA lowering? And so I think the idea that imaging is going to tell us who has disease, but it tells us nothing about the biologic reason this particular person has the problem. So I think we're at a point where if we can marry the biomarkers and the imaging, I think we'll have a future here.
And that allows you to do more personalized treatment for that particular patient.
Right. We've got to get past this idea that everyone's atherosclerosis is the same.
Right.
We lived in that world for 30 years because we really just had statins. But now we have many other ways of getting there and very new biology coming online. We have to get to personalized prevention.
So tell our audience, what's the panel of biomarkers specifically that you order? What do you find most helpful in a preventive cardiology practice?
I'm a pretty simple guy, Bob. So we just published this paper in the New England Journal in December where we had 3 things. We just had the LDL, the hsCRP, and the Lp(a). All 3 predicted 30-year outcomes. All 3 were completely independent of each other. And they're 3 things I can actually modify.
So they all contribute information to the risk.
Some people have 1, some people had 2, some people had 3. And what was really interesting is the patients who had all 3 elevated, their risk was actually much higher than what the prevent scores were telling us anyway, and vice versa. So not only was I getting a sense of that their risk was, but now I could say to them, yes, I need you to stop smoking. I need you to go to the gym. I need you to do X, Y, and Z. But I also need you to think about getting your cholesterol down for this patient. I need to target your inflammation for that patient. This one, I really need weight reduction in a very serious way. And if the LPA trials work out, I think we'll have another access to this. So it's really trying to figure out not just what's your risk,
but what can you do?
What can do about it?
Do you check HDL?
I do because my patients want it. It's like
without a therapy to...
But it's kind of like triglycerides. Right. I don't really know what I mean, if the triglycerides are extremely high, that's a different issue. But, you know, we've had guidelines asking us to measure triglycerides and HDL for 40 years, and I don't really act on them.
Because we don't know what to do.
Right.
What about hemoglobin A1C? Do you routinely get that?
It's a routine part of what we do for other reasons in the metabolic sense of things. What's interesting is I started to get GFRs when the new data came out, and they're all normal. Because I kind of like, I already know who has kidney disease. So I actually must say on that piece, I'm sort of like, but that's all right.
What are you doing, Fatima?
Yeah, again, my clinic is so preventive that a lot of the patients will just show up already with a set, all the Boston's, lab panel, Quest, and most of the time I'll tell you that I don't use any of the information, but it is helpful to track. For a lot of patients, ApoB is the most useful. HDL and triglycerides are important markers, right? And I think especially the triglycerides for insulin resistance, HDL, unfortunately people are like, my ratio is good. And I actually saw that in a physician's note the other day. LDL is high, but HDL is also high, so they're all good. And we need to obviously move away from that.
It's called a teachable moment.
Yeah,
right.
Exactly. So we wrote a nice letter to the referring clinician. But I think those exactly right. We have to have something to target. And I'll give you a very specific example. I had a patient with a very low LDL, 60, on a lot of therapies, primary prevention. She had a CCTA that was done for other reasons, and we did a plaque analysis on it. She had a lot of non-calcified plaque. So I said, for you, let's consider what else is going on. Let's intensify your antithrombotic therapy. Yep. Let's think of anti-inflammatory therapies. Let's get that LDL to a lot lower, because for you, this is obviously not enough.
Are either of you using colchicine in the primary prevention population? Most of the data is in the secondary prevention.
So I got to be very careful here. So in secondary prevention, is different. Chronic stable angina, I have a lot of patients who are candidates for colchicine. I think it's a remarkably underutilized drug.
I was using it for secondary prevention.
It's incredibly inexpensive, and it seems to work very well. Primary prevention, I've been holding off. There are some patients who have very high scores with the imaging, who I almost treat like secondary prevention. Jean-Claude Tardif is doing a trial in very high-risk primary prevention. But there's so many patients who should be on the drug in secondary prevention. I think if we start there, we'd be a good thing.
What are you doing?
Completely agree.
Okay. What about LDL in primary prevention? Are you trying to go as low as you can go? We now have a lot of tools in the toolbox, right? We got statins, we got PCSK9, we got ezetimibe, we got bempedoic acid. I mean, we got a lot of ways to lower it.
So let me take a step back and say what we've realized with imaging is there's really not these clear-cut primary, secondary prevention, right? It's really a continuum of risk.
I used to call it prevention 1.5.
That's right. Yeah. We used to call that in clinic. So once they have atherosclerosis, they have the disease. So again,
So are they primary or secondary at that?
so at that point, you know, I don't want to wait for them to be high risk secondary prevention to have an event. I don't treat those patients as primary prevention, and those lipid targets, I'm not targeting LDLs of under 100, which for primary prevention may be appropriate, but a lot lower.
What's a lot lower?
Under 70, I think is when there's some atherosclerosis, ideally as low as you can go. I think all of us in the preventive field don't see a downside to going as low as you can go.
So it's interesting.
You are the Eugene Brunwell professor who says that you can't have too low an LDL.
Yes, and it's almost true that we almost always agree. No, but look, I think it is true you can't be too low. It's not dangerous. We all understand that. I think the question is the financial incremental cost to get your LDL from 70, which most people on a high-intensity statin can get close to, down to 40, it starts to become exponentially expensive for a pretty small absolute risk reduction. Our trials are pretty much based on relative risk reductions, but the absolute risks are getting very small. Yeah. What I'm concerned about is that, and we've published now lots of data, that in secondary prevention on a statin, it's the CRP that's telling us about your likelihood of dying and likelihood of having a recurrent event, not the LDL. The LDL is pretty well taken care of with a high-intensity statin alone. That doesn't mean I don't use the ezetimibe. Of course I do. I use bempedoic acid. I add drugs on. I have patients on PCSK9 inhibitors. But most of my patients, once they're on a high-intensity statin, I'm more concerned probably about their CRP, and I'm going to start thinking about colchicine. I'm going to start thinking about other ways of getting them to do things, weight reduction. That is, to me, the untapped potential here. Yes, the trials work, but
Tamp down the inflammation at some point. Yeah.
And I agree, just to build on what you said, that one of the values of imaging is to show who should have these more expensive therapies, right? Because I think there's a lot of great therapies out there. I mean, the SGLT2 inhibitors, I say they're like the new statins, right? GLPs, they're really game changers for prevention, but does everyone need every drug? Probably not, especially when we think about the cost of these drugs and the population benefits. So imaging is extremely helpful to help guide that.
One last question. Same question for both of you. I'll start with you, Paul. What are you most excited that's coming down the pike?
Oh, I gotta tell you, I think cardiology is in an explosive area. I walk through these meetings. I learn so many things I didn't know about. I think we all get kind of focused in our area to see things happening in heart failure that are mind-blowing compared to where we were just a few years ago. The whole ATTR situation, a disease that most of us didn't even know existed, suddenly has 4 incredibly effective therapies. That excites me because that means science and biology are coming into our field yet again, and that's great. You've already mentioned one of the downsides. It's getting kind of expensive, and we're going to have to figure out as a society who does need these various things. But from a scientific point of view, I mean, and think about the stuff going on at Verve. Think about the things going on in terms of, you know, genetics. It's a pretty exciting time.
Yeah, it's interesting the way you said it, because for a while, I think a lot of us were a little depressed that every drug we had was generic, which meant that there was nothing new. There's beta blockers and statins and ACE inhibitors. And like, well, where's the new stuff? And now, as you say, there's been an explosion, and it's driven by science, and it's driven by discovery science and figuring out new mechanisms of disease. And I agree with you, that's exciting.
This is the hardest question because there's so many exciting things in prevention. I would say the first is that there are things now that are outside of our lane of atherosclerosis, the cardio-kidney metabolic syndrome, and all the therapeutic areas, why cardiologists need to know about the liver, the kidneys. Like, it's so exciting to keep learning this and to help our patients, because our patients are really one patient being taken care of by many specialists. So how do we bring that care together? And then the second thing is this new excitement around the science on treating residual risk, which is, I think, a lot what you're talking about. Some of it is inflammation. Some of it we just don't know yet. Is it the lipoprotein A? So just the data that will come out of that in the next few years.
To try to understand where we might go.
And it may be different for each patient, right?
Well, this has been really fantastic. I want to thank Paul Ridker, Fatima Rodriguez. Thank both of you for joining. For the listener, we hope you've enjoyed it. Please drop us a comment, give us a thumbs up, or, you know, occasionally a thumbs down if you didn't like it. Let us know what we can do better. Let us know what other kind of things you'd like to see us discuss with the experts that I'm always running into at meetings like this. So this is Bob Harrington from Weill Cornell Medicine, thanking you for listening. Medscape Cardiology and theheart.org.